Good afternoon, everyone. It's a huge pleasure for me to talk about the latest scientific findings and future perspectives in immuno-oncology. I'm not going to talk about novel drugs, novel technologies, nor novel approvals of immunotherapeutic drugs. I'm just going to talk about what we can do to improve the efficacy of immunotherapy that we already have, and what we can do not using drugs, but using a different way how we look at the immunotherapy activity. First, what I want to stress is that actually over the last 30 years, we've learned a lot about how the immune system works, and what we've thought about the mechanism of immunostimulation back 30 years ago that was pretty straightforward. It's not that straightforward anymore because it's much easier to inhibit the immune system than to stimulate it. And based on this knowledge, we actually understood what we should do to release the activity of immune system and to find the cancer properly. So first, what I want you to understand is that lymphocytes, that are the primary cells responsible for killing tumors, are extremely sensitive to immunostimulatory signals once naive. So it's pretty easy to stimulate lymphocytes to make them activated and proliferating. But actually, those lymphocytes cannot proliferate forever. The immune system is so constructed that it must be homeostatic. So the cells must be inhibited at some point, just to keep them at the low number, because once activated without any breaks, it can be only one population of lymphocytes proliferating. It's like in leukemia. So the more activated, the more sensitive to immunoinhibitory signals. And it actually turned out that once the lymphocytes are inhibited, they are not active. It's really very, very difficult to reactivate them using stimulatory factors. So that's why immunotherapy failed so many times over the last century, because we tried to overactivate. And now we know that we just need to release the brakes. We need to dismount the brakes, and we will regain control of the immune system over the disease, because we just need to make the lymphocytes active again. So we just need to use drugs, checkpoint inhibitors, that are releasing the brakes. And using those checkpoint inhibitors, we were able to make the tremendous progress in cancer treatment using novel immunotherapeutic drugs. Why it's so active in some tumors? It's because we just need to release the brakes, and the immune system will know what to kill. Why? Because there are some tumors, those here, that are extremely mutated, and every single mutation can lead to generation of a novel neoantigen, and the more antigens in cells, the more immunogenic the tumor is. So those tumors that are caused by long-term exposure to carcinogenic factors like UV radiation or smoking are highly mutated, are highly immunogenic, and it's just about to release the brakes, and the system will kill what it has to kill. But why is the problem that not all patients respond to the treatment? Actually, in many different tumors, there are immunogenic less than 50% of patients will respond. It's because there are some other factors that influence the activity of immunotherapy. And one of the most important factors is human microbiome. It's the cells that create the microbiome. There's 10 times more cells than the cells in the human body. It's more than 10,000 different species. And when we talk about gut microbiome, we have to remember that we are not only talking about bacterial microbiome, but we are also talking about viral and fungal microbiome. The microbiome that we have is vertically transmitted during delivery, but is modified by us over the whole life. And when we talk about gut microbiome, it's more than 3 times 10 up to the 13th of bacteria, mainly commensal bacteria, that have critical role in generation of innate and adaptive immunity. And actually, the gut microbiome regulate the balance between inflammation, infection, and tolerance to food and commensal antigens. And there is a lot of different factors, a lot of different drugs, a lot of different food parts that may modify the gut microbiome, and that actually may shape the final immune response that we observe in our patients using, for example, immunotherapy. Do we have proofs? Sure. Look at this slides, administration of antibiotics within 30 days prior to initiation of immunotherapy, and you see that patients who have been treated with antibiotics are not responding to immunotherapy compared to patients who have been not treated with antibiotics. And when you look at these curves, there is no doubt patients who have been not treated with antibiotics, they have really good prognosis compared to the orange curve of patients who have been treated with antibiotics prior to initiation of immunotherapy. Next example, in lung cancer, the activity of anti-PD-1 therapy decreases with the use of antibiotics prior to initiation of treatment. So you see more patients on antibiotics are progressing, less patients are responding to the treatment. And when you look especially at the right-hand side cartoon, you see that the difference in median overall survival is really striking. More than 2 years of median overall of patients who have been treated with immunotherapy without prior antibiotic treatment, compared to less than 8 months of patients who were treated with anti-PD-1 checkpoint inhibitor, but have been treated previously with antibiotics. So it means that role of antibiotics, the role of microbiome is crucial in the activity of immunotherapy. And we know that antibiotics can shape, modify the gut microbiome, that the concentration of microbiome, the diversity, particular species are really crucial for the response or lack of response to immunotherapy. What we even know that when we have mice, germ-free mice that have no gut microbiome, and we make them harbor tumors, and we want to test immunotherapy, when we transplant gut microbiome to those mice from patients who responded to immunotherapy, those mice will respond to immunotherapy. And when we transplant gut microbiome from patients who have not responded to immunotherapy, the mice will not respond, will not reject tumors, even though we use immunotherapy with checkpoint inhibitors. So the higher the diversity of microbiome is, the higher the chance of response to immunotherapy is. And therefore, we thought about maybe we should use probiotics to, modify the microbiome to stimulate the immune response. It's wrong. It turned out that using probiotics, actually you decrease the diversity of microbiome than increase it. So using probiotics, you decrease the probability of response to immunotherapy, you decrease the diversity of gut microbiome. But what you can do, you can make your diet high fiber, and then at that time you have 5 times increase the chance of response to immunotherapy. So the whole grain diet, high fiber diet, promotion of pro-response bacteria, processed meat, added sugar, inhibition of pro-response bacteria. So is it really only about this diet, what we can do about increasing the efficacy of immunotherapy? No, because it turned out we can consider stool transplantation from patients who responded to immunotherapy, and such trials are ongoing. And hopefully we will be able to show that in some patients who are not responding to immunotherapy at the beginning, we may consider stool transplantations from responders, and we may be able to give them the chance to get the benefit from immune treatment and to achieve the long-term immune response and long-term survival. Thank you for your attention.